Hi, everyone. I am Caitlin Sylvester with the American Cancer Society National Colorectal Cancer Roundtable, and it is my pleasure to welcome you to our program today. We are here to celebrate March, National Colorectal Cancer Awareness Month, and to recognize all of the great work of the partners across this country working to save lives from this disease. We have a very special program lined up for you today with some exciting guests joining us. Um, and today we'll hear from Roundtable leadership and their thoughts on the state of the field of colorectal cancer. We'll learn about some recent colorectal cancer screening data and trends. You'll also hear about the amazing work of our 2025 National Achievement Awardees and then explore some opportunities where we can further our impact. So before we get started, I do want to let everyone know that our webcast is being recorded and it will be available on our website in the upcoming days. We're also hoping to break for questions several times throughout the program. So you should see a Q&A box at the bottom of your screen. Be sure to put your questions there. And then, of course, as always, engage with us on social media. We always love to see what you're doing throughout the month of March and throughout the year. So before we move to our first panel, I do want to share with you some three areas that has really been guiding our work throughout the month of March. And I think it's three actions that all of us can take. So first of all, if you're of average risk and you are 45 and not up to date on screening, go get screened. And if screening is recommended earlier for you, please talk to your doctor and find out when screening is recommended. Also, encourage your family and your loved ones to get screened. Don't underestimate the impact that you can have, especially when talking about symptoms or family history. And we want to help you by offering our ACS resources. Make a plan to use tools and resources to do more to promote colorectal cancer awareness in the communities that you serve. So now, to kick us off, it is my pleasure to welcome our ACS chairs, Dr. Stephen Itzkowitz, Professor of Medicine and Oncology Sciences at Icahn School of Medicine at Mount Sinai, and Dr. Gloria Coronado, Associate Director of Population Sciences at the University of Arizona Cancer Center. Hi, Stephen, Gloria. Thank you so much for being with us today and for your continued efforts in championing our shared work to save more lives from colorectal cancer. It's so great to see you and hear from you. So Steve, talk to us about why this month continues to be so important for the Roundtable, our members, and our partners.
Thanks, Caitlin. March is really important. As Colon Cancer Awareness Month, it really gives us a chance to step back and look at where we are and where we need to go. And despite all the progress that's been made in screening and treatments, unfortunately, colon cancer still ranks as the second most common cause of cancer deaths in the United States, with about 155,000 new cases and about 53,000 deaths, which is very unfortunate because colorectal cancer is arguably the most preventable cancer. And while I'm heartened to see screening rates improving nationwide, we still have a lot of work to do, as you'll hear in the next hour. But March also brings us hope. I'm always heartened and energized when I see the incredible commitment, passion, and innovation of all of our members and our partners, some of whom you're going to hear about today. And our progress in increasing screening rates also translates into breaking down policy barriers. And as you know, we really had to pivot and innovate during the COVID pandemic. And we did all this because we can, and we work together. And all of this shows what kind of a difference we can make when we do work together.
Absolutely. And it's so true. And I just have to say, it's very exciting to see everybody who's joined us here today. We had almost 500 people sign up for this webcast, so very exciting. Gloria, I'd like to turn it over to you. Share with us what March means to you.
Yeah, March is really a time to get energized about colorectal cancer screening. So I think there's two times of the year that I feel an infusion of energy, and one is November during the annual meeting of NCCRT, and the other is March when we get to hear about all the activities that are taking place around the country and get to hear from advocates and survivors of colorectal cancer. And so I look at it as a time to really kind of feel the spirit of people's engagement at the community level, people's interest in really sharpening their goals and taking action to increase our screening rates and save more lives from colorectal cancer.
Absolutely. And Steve, I'm wondering if you could share a bit about more what NCCRT is doing, not only around screening, but to make impacts in other areas of colorectal cancer.
Yeah, as I shared in the annual meeting, we're not only been focusing on screening, but also we're thinking about moving into the continuum, what we call the cancer continuum. And if I can, I just show a couple of slides that I think schematically demonstrates what we're talking about. So for its entire existence, the NCCRT, the roundtable, has really been focusing on the screening side of things, because if we do adequate screening, we can probably reduce mortality by about 65%. So there's no doubt that adequate screening reduces not only the incidence of colon cancer, but also the mortality. But screening has to be done properly. It has to be done well. If you do a stool-based test and it's abnormal or positive, we have to really be sure that people are going for colonoscopies. And colonoscopy is often the primary screening test for many people as well. Unfortunately, if people don't get screened or are inaccurately screened, they may eventually develop symptoms, which then will lead to colonoscopy or diagnosis of cancer by other means. So all roads kind of lead to colonoscopy in terms of diagnosing cancers. Once a cancer is diagnosed, then we're moving into what we call the cancer phase. And a lot of it depends on the stage at which cancer is detected. So if I can have the next slide. So timely colonoscopy is critical for taking abnormal stool tests into colonoscopy. But also what we're talking about now in the roundtable is the continuum. So once somebody is diagnosed, getting them into treatment very quickly, very timely. And the next slide, please. When somebody is diagnosed with cancer, it's important that that individual undergo genetic testing to see, because it may change their management, but it would certainly impact their family. We may identify high-risk families. Also, the tumor can be tested with various biomarkers, which then guides treatment and therefore improves survival. So while this is a daunting task to think about tackling the entire continuum, we are moving towards some of these aspects with the roundtable in terms of keeping our goal and efforts on screening, but also thinking about moving into timely treatment for colon cancers that are diagnosed. Next slide, please. The reason why colon cancer is so preventable is that there is a very well-defined precancerous phase in the polyp, the adenomatous polyp. And just to lay out a few terms, you'll hear the term tests that are geared towards preventing colon cancer, and tests that will detect cancers early, meaning stage 1 or maybe stage 2, because survival is better at these less invasive stages of cancer. So when you think and hear and read about the various types of colon cancer screening tests, just pay attention to tests that can prevent the disease, meaning they can detect polyps adequately, as well as tests that can detect early stage cancers, and therefore survival will be improved.
That's so true, Steve. And Gloria, I just wanted to pass if there's anything else you'd like to add or share about our priority areas.
Yeah, I'm really, so a couple of things to add. One is that I recently learned that 80% of the benefit of screening comes from the removal of polyps. So it comes from the prevention of colorectal cancer. And so I think just to underscore what Steve mentioned, that it's really important to consider screening tests that do a good job of finding polyps so that those can be removed during the colonoscopy procedure. In terms of the priorities for the NCCRT, really excited about obviously mobilizing community level efforts for health equity, improving timely action for early onset colorectal cancer signs and symptoms. And I would say that this has been a longstanding commitment and interest of the NCCRT, as well as various other organizations that are concerned with colorectal cancer, supporting on-time screening and supporting as well timely follow-up colonoscopy. And this is an area that I take great interest in because we know that the rates of follow-up are lower than we'd like them to be. So across the country, they vary from about 50% in federally qualified health centers to about 70% in integrated delivery systems, 70 to 80%. But we'd like those proportions to be much higher because we know that individuals that get timely follow-up to an abnormal stool-based test are more likely to have cancer detected, are more likely to survive when they do have that cancer detected because it's at an earlier stage. And then timely initiation of quality colorectal cancer treatment. This is a new area for NCCRT to really look more downstage, to think about whether there are delays and whether we can reduce those delays of people getting treatment once they are diagnosed with colorectal cancer.
Yeah, I absolutely agree. And thank you both so much. We will be circling back to hear more from our chairs later in the program. So thank you both. As a reminder to our attendees, be sure to check out our chat. We are putting links to all the websites, resources, and everything that we're discussing during the call. And I do want to take a quick moment before we transition to our next speaker to share a video from a colorectal cancer survivor named Todd.
We first discovered that I had cancer in December of 2019. I actually had my routine colonoscopy. I had some previous signs that something was off and that I should have probably had that screening a lot earlier in the year.
Great. And, I just want to start off by thanking Todd for not only sharing his story, but allowing it to be recorded as part of ACS's I Love You Get Screened campaign so that we could share with all of you today. I think it's so important that with everything that we do, we hear the patient voice and incorporate it and have it ground us in our work. It's really important that we remember why we do what we do and that why we serve the folks that we serve. His story is also so significant because it highlights how important it is for us to not only advocate for ourselves and our own health, but also those around us, our patients. We all play a role in encouraging our family, our friends, our patients, our community to get screened. And I will say we will hear from another survivor later in the program. So kind of piggybacking off of this, I want to share that the American Cancer Society just launched a partnership with American Greetings, which allows you to share a digital greeting card with a loved one, encouraging them to get screened. So you can follow the link in the chat, take a look, you can pick out a card, and then you can send it. And you never know, it could make a huge difference. We've also curated a list for everyone of educational materials from the American Cancer Society. And these are really focused towards patients. It includes brochures, infographics, and a new comprehensive cancer risk assessment tool called ACS 360. So be sure to check that out and you can determine your own risk as well. And again, we will share all of these links in the chat and in a follow-up email. So it's now my pleasure to welcome Dr. Priti Bandi, Scientific Director of Risk Factors and Screening Research with the American Cancer Society. Priti is joining us to share us the latest data on CRC screening from the National Health Interview Survey. Again, if time allows, we will break for a couple questions, so please submit your questions in the Q&A box at this time. And again, Priti, thank you for being with us today. I'll now pass it on to you.
Thank you, Caitlin. So I'm going to talk today about colorectal cancer screening trends. I'll focus on the time period between 2019 and 2023. So the period that we know spans the COVID-19 pandemic. So next slide. I'm going to give a little bit of a primer on the data set that I'm going to present on. It's called the National Health Interview Survey. And it is the preeminent survey that we use to track cancer screening behaviors in the US population. And why it's so great is that it is nationally representative. So we can make generalizations to the US population of non-institutionalized adults. So screening has been tracked in the NHIS from the 1980s, but as recommendations have changed, they've added different questions. What are listed here are what are being tracked currently. And we have colonoscopy, sigmoidoscopy, stool-based testing, and most recently Cologuard testing was added. And I will focus on the time period between 2019 and 2023 because we really can't look at data before 2019 due to changes in the survey design. So next slide. Before I jump in, I just want to make a plug to a biannual surveillance publication that our team puts out. It's called the Cancer Prevention and Early Detection Facts and Figures. Much of the data that I will present in the next slides are going to be published on April 23rd in our upcoming release. So do check it out for state level and national level screening estimates. Next slide. The first part of this, I will talk about screening rates among all age-eligible populations. Now, the data present are consistent with the ACS guidelines of 45 and over. And I'm presenting here data between 2019 and 23. Each of the bars represents those time periods and the prevalence estimates in those. Here I've given modality-specific estimates, right? And what you see is that during the pandemic, the period that spanned the pandemic, there was a significant increase in stool testing that happened, a 45% relative increase during the early part of the pandemic between 2019 and 2021. Colonoscopy increased more recently between 21 and 23. And so overall, over this time period of the pandemic, we actually saw that overall colorectal cancer screening among all adults eligible increased marginally by about 8%. We recently published a study in JAMA that reported that there have been rebounds in colorectal cancer screening after the pandemic. So do check that out as well. Next slide. Now I'm going to present some new data on the newly age-eligible population of 45 to 49-year-olds. Now you will know that in 2018, the American Cancer Society, they expanded the age eligibility by reducing the age to get screened from 50 to 45. And this was in response to much of the research that came out of our team that showed that the risk of colorectal cancer screening was really increasing among younger generations at the younger ages. So we have now this newly age-eligible population in 2018, but it was only in 2021 that the USPSTF, the United States Preventive Services Task Force, reduced their guideline, also the recommendation to be screened at 45. So we assessed in this study published in the Journal of National Cancer Institute last year how screening rates had changed in this newly age-eligible population of 45 to 49-year-olds through to 2021. And unfortunately, at least until 2021, we did not see that there was much change during that period, right? In 2021, there were about 20% of the eligible folks were screened according to recommendations. Of those, about 17.8% were screened by colonoscopy, and only about 2% were screened with stool-based testing. But we do have one more year of data now, so that's what I'm going to present to you in the next slide. And here you will see the first set of bars is for the newly age-eligible population. And indeed, in 2023, we saw that there was a sharp jump up in screening rates among this newly eligible population, a 62% relative increase. So it was in 2023, about 34% of ages 45 to 49-year-olds were screened according to recommendations. You'll see that this time, this change is isolated to the 23 time period. And it didn't occur in any other age groups that were also eligible. So it really kind of isolates the impact of the USPSTF recommendation change. All right, here the slide kind of stratifies it or separates it out by this modality, the screening modality. We actually saw increases in both stool testing and colonoscopy among this new population. 82% increase in stool testing, but it still was only around 7% that was screened by stool testing, and a 30% relative increase in colonoscopy testing. And in 2023, about 27% was screened using this colonoscopy modality. Next slide. So I'll summarize. I know I went over it quickly, but during the COVID-19 pandemic, there was, in kind of contrast to other screening changes, at least for colorectal cancer screening, there was a marginal steady increase of about 8% in all age-eligible adults. And this was largely driven by kind of stool testing, increasing during this time period and making sure that screening did not decline among all those who were eligible. And in the newly eligible population of 45 to 49-year-olds, there was a sharp jump up in 2023 on screening in this group. About 1 in 3 individuals were screened according to recommendations. And, because we were able to isolate that, it really happened after the USPSTF guideline change. And we know that the guidelines, the recommendations are linked to insurance coverage determinations, right? So it really kind of highlights the crucial role that health insurance coverage and access and cost still continue to play in health behaviors and cancer screening behaviors. Stool testing is still underutilized relative to colonoscopy, and it highlights, the possibility and the potential for stool testing to kind of improve rates among this newly eligible population. So thank you, and I'll take questions if you have any.
Wonderful. Priti, thank you so much. We always learn so much from you. I do believe we have time for 1 or 2 questions. So do you know if the National Health Interview Survey is planning to start asking questions related to blood-based cancer screening?
At least from the questionnaires they've released so far, no, not yet.
Okay.
Yeah.
Wonderful. Let me see if we have any others coming in. Okay, so we are going to move on. Priti, again, thank you so much.
Thank
It was so
you.
wonderful having you join us today. So we'd now like to shift gears by showcasing some of the great work that's happening around the country to increase colorectal cancer screening rates. I would like you to please join me in congratulating our 2025 NCCRT National Achievement Award honorees. This award is actually in its 10th year and is quite competitive, and these honorees represent a diverse group of organizations, including community health centers, health systems, health plans, and other organizations. We do have 2 representatives from our awardees with us here today, but before we get to them, I would like to quickly share about the other 3 organizations. Starting off with Marshall, they are out of California, largely rural population, and they focused on screening 45 to 49-year-olds and have increased their screening rate by 3% in the last year. So cheers to them. Also, People's Health out of Louisiana, they are a Medicare Advantage plan who've worked to eliminate the screening disparity between their Black and white members. And Project 80 out of the University of Texas, MD Anderson Cancer Center, who through navigation have a 75% colonoscopy follow-up rate following stool-based testing. So cheers to them. I am now thrilled to introduce you to 2 of our honorees, Dr. Miranda Hart, Senior Medical Director of Integrated Primary Behavioral and Population Health at Erie Family Health Center, and Dr. Linda Durham, President and CEO at the Georgia Center for Oncology Research and Education. Welcome and congratulations to both of you. Miranda, would you share with us a bit about the Erie Family Health Centers and the community you serve in Chicago?
Absolutely. Thank you so much for having me. Thank you so much for this honor. We're so excited to showcase the work that we do at Erie, particularly as it relates to screening for colon cancer. So Erie is a federally qualified health center in the Chicago area. We have 13 locations, 7 of which are primary care centers and 5 of which are school-based health centers. And 2 of our school-based health centers also serve the community in which they are located, and we have 1 center that's dedicated to teen and young adult health. We also are opening a new health center next year in the West Garfield Park. Will be particularly relevant to screening for colon cancer because it's an area of the city that has much lower rates of that. So excited for that. Next slide, please. We have over 95,000 patients at Erie, for which we provide 391,000 visits annually. Our patients come regardless of their ability to pay or insurance status. So about 94% of our patients are what's considered low income. Just over 2/3 of our patients have Medicaid, and we actually have 21% of our patients who have no insurance at all. Almost half of our patients don't speak English. And of all of our patients, a little bit over 2/3 are Latinx. Next slide. So we can go to the next slide. We're really proud of the work that we've done at Erie to increase access to colorectal cancer screening and care. Last year, we screened over 16,000 patients for colon cancer. That represented a 20% increase from the previous year. We increased up from 49% to 59% of our patients, which we're really proud of. That exceeds the national FQHC average rate, which is about 46%, and actually is in the 90th percentile for FQHCs. We introduced a lot of different methods to help improve our screening rates and also our rates of follow-up, from positive fecal testing to colonoscopy. So one of the things we did was we introduced a novel fecal screening method with fecal DNA. We did a lot of outreach directly to patients in their preferred language and provided education for them in their preferred language as well. We supported a team of health navigators who can help patients to schedule their colonoscopies, arrange for transportation, address any insurance barriers or lack of insurance barriers, and really worked hard with our hospital partners to make sure we have direct access for colonoscopies for our patients who have positive fecal testing.
Wonderful. I mean, phenomenal work. Again, congratulations. I was wondering if you could just share a bit more about why you decided to prioritize colorectal cancer screening across your system.
Yeah, there was a couple factors that went into that. One is just we actually saw a drop in our colorectal cancer screening rates during the pandemic and knew it was an area of focus that for us as an organization because of that, and also really wanted to get up to speed with screening our younger patients between 45 to 49 when not just the USPSTF recommendation change, but also the metrics that we are evaluated on in terms of quality with the federal government. They dropped our age down to 45 as well. And really, we wanted to push to get those patients who had never been screened before screened for colorectal cancer. And I'll answer the question in the chat. The novel screening that we introduced was the Cologuard test, the fecal DNA testing.
Great. Yeah, thank you so much. And Lynn, would you share a bit with us about Georgia Core and how your organization came to focus on colorectal cancer screening?
Sure, absolutely. Thank you. I'm really happy to be part of this today. Georgia Core is a statewide nonprofit, and we are dedicated to reducing the burden of cancer in Georgia through research, education, and advocacy. And we were created 22 years ago to provide access to clinical trials and other life-saving treatment. And since then, we've broadened our scope and work as a convener of the oncology community and as a resource for providers, survivors, elected officials, and others. And so at the urging of the Georgia Colorectal Cancer Roundtable in 2020, Georgia Core became the lead partner in our application for the CDC's Colorectal Cancer Control Program. Southwest and Southeast Georgia are mostly rural, and their screening rates lag behind the rest of the state. And so we knew those were areas we really wanted to concentrate on. So we went out and got partners because that's what we do best. And so we developed partnerships using their expertise with Augusta University, the med school there, as well as the School of Public Health, to work with us. And then also Horizons Community Solutions. They are one of 5 cancer coalitions in the state, and they concentrate a lot on patient navigation. And so we wanted to make sure that they were our partners in this. And so throughout the 5 years, we've also added 3 FQHCs, and I'll say those are the East Georgia Healthcare Center, the Albany Area Primary Healthcare, and Primary Care of Southwest Georgia. And we have 20 clinics that are part of our program, and they've been doing fantastic work. We're in our 5th year now of the grant.
Wonderful. I mean, again, also congratulations. It's incredible work. I was wondering if you could share a bit about the strategies you're using to reach individuals from across the state.
Sure, absolutely. Well, I mentioned great partners, and we have incredible partners, and they're really the drivers of our strategy. So Dr. Jim Hotz of Albany Area Primary Healthcare and Dr. Kush Desai of Augusta University are our medical directors of the program, and they, along with our clinic liaisons, really work to implement the EBIs, the evidence-based interventions, in these different clinics to make sure that we are getting to the patients, to the providers through reminders, that we're using patient navigation, and all of the 5 EBIs that the CDC recommends as part of their program. So we work with them. We also have worked with Augusta University. They are an evaluation team, and they've really come up with some great ways to evaluate the data and the actions of what's happening. One of those novel ideas is an engagement tracker. So they track all of our engagements, whether it be within the partnership or outside the partnership, so we can really see who we've been talking to about this, who knows about it, what we're doing. And so that has been a great part of this. Also, our Augusta partners came up with the TeleEcho program. We know that's out of the University of New Mexico. We have taken that and made a monthly colorectal cancer screening TeleEcho that is run by our Augusta University partners. And then we have our providers log on once a month and talk about best practices, talk about challenges, whatever they may have in the program. And so it's really allowed those people to work together, to talk together about what the issues are and find solutions to any issues.
Wonderful. Thank you. So back to you, Miranda. You have been at this work for just over a year. What are some of the early results that you're seeing?
Well, one of the really gratifying results is that we've been seeing is the impact that our navigation team has had on the both the percentage of patients who follow up with colonoscopy, as well as the duration of time between positive fecal testing and colonoscopy. We've had significant improvement in that just by doing proactive outreach to patients, make sure that they got the referral, make sure they know how to call for the appointment, make sure they have a ride. Those types of things have made a huge difference. It's a small, they're small things, but they make a big difference in terms of our patients' ability to actually get their follow-up testing. Additionally, we implemented a bulk screening process where we, on a population health level, just look at our patient population that's due for colon cancer screening and order those tests for them proactively, so they get delivered to the patients' homes. And then our providers, in the setting of an office visit, will remind patients that they are due for their screening test and make sure that they got the kits and are able to return those. So we've had a lot of success with that too.
Great. And Lynn, your initiative has been at this for several years. What sort of results have you been seeing?
Well, we onboarded these 20 clinics over 5 years and worked with them to drive all the numbers up. The clinics, all of our clinics, all 20, have seen increases in screening rates. But that was impacted once the age went to 45. And so some of the clinics have now dipped below, but we're still continuing to work with them now with patients ages 45 to 75 to make sure we have all of those ages. But in our East Georgia clinics, the average screening rate went from 33.7% to 44.5% in that 4 years and 4 years time. And so we're really proud of the work they have done there. And in Southwest Georgia, those two different FQHCs, one has increased by 2%, the other has increased by 4%. But to be honest, we really like to talk about this and the number of lives impacted and lives saved. And so in Southwest Georgia, less than 10% of the stool-based tests, because our program is a stool-based test first, so FIT first program. So less than 10% of the stool-based tests were positive. 880 patients had the adenomatous polyps, and only 5 cancers have been found out of over 6,000 patients. And in the Southeast, 15% of stool-based tests were positive. 99 patients had adenomatous polyps, and only 2 cancers have been found over about 2,500 patients. So I want to tell just a really quick story about a man in rural Georgia. He lives in a very rural area. He was going to his FQHC for a checkup, and his provider convinced him to take a FIT test. He didn't want to do it, but she convinced him. Well, it came back positive. During a colonoscopy, it was discovered that he had stage 1 colon cancer. He was 50 years old. He was treated surgically and is cancer-free, and he has been very grateful. And he says even though his mean provider made him do it, he's so grateful. And so real lives are being saved.
Oh my gosh. And, we love a clinician recommendation for screening. So it's so important. Thank you so much
Yes.
for sharing that story. So before we wrap this program, I know there are folks in our audience who are maybe just getting into this work, or maybe trying to learn how to take their initiative to the next level with maybe, bold goals, new ideas. So Miranda, what sort of advice would you have for our listeners?
I think for our patient population in particular, the most important thing is to really meet patients with where they are and figure out how to get them screened, whatever mode works best for them. So, some of our patients who don't have stable housing or don't have access to a bathroom to do a colonoscopy prep, it's really easiest to give them a fit test in the health center, have them even collect the sample while they're still there, and then we have them screened. But other patients, it's easier for them to not have to leave their home and to be able to do it all from the comfort of their own home. So meeting patients where they are and providing culturally sensitive, comprehensive options for patients is really the best way to get them screened.
Definitely. And Lynn, what advice would you like to share?
Well, I've talked about partnerships throughout this, and partnerships matter. Really finding good partners that you can work with really makes a difference, and everyone has to be devoted to this. We found that through our lead partners and through our FQHCs, and also really good flow of communication. We have partnership council meetings every 2 weeks. We talk through all the issues, figure out what the problems are. We have 3 teams: administrative, evaluation, and implementation, and we all work together, and we're all talking about the same issues. So anyone can come up with an idea, anyone can make an improvement, and it's really been a wonderful collaborative effort.
Absolutely. So in just a moment, we're going to take a couple questions from the audience. So a reminder for everyone to please submit through the Q&A box. But while we're doing that, I just want to quickly share a few ACS resources that can help support these sort of implementation strategies. So first of all, so anyone who's working with primary care practices, our Steps for Increasing Colorectal Cancer Screening Rates manual is a really helpful tool for creating and designing and sustaining a screening program in primary care settings. We've also recently updated our clinician's reference, which is a brief for primary care clinicians to showcase the value of offering stool-based testing alongside colonoscopy for average risk patients. And lastly, we've been talking about this, getting screened on time, the importance of clinician recommendations, talking to your family. Our lead time messaging guidebook really highlights the best messages to use, tips and strategies and tactics to make sure that those messages really resonate with folks. Okay, so we're going to take a couple of questions from our viewers. For Lynn, do you have any suggestions on how to have a successful CRC awareness marketing campaign from a GI practice with patients or primary care offices?
Wow, great question. So we're actually just embarking on one. In Georgia, we're so grateful that the General Assembly and the governor just approved $250,000 allocation to Georgia Corps to pull together a campaign on young onset colorectal cancer and to get the signs and symptoms out there. We're really focused on signs and symptoms and making sure. I just came from the Fight CRC call-on Congress up in Washington. Last night I got home, and so many people talk about they never knew what the symptoms were. They didn't know what a colonoscopy was. They didn't know what their colon was. And so really trying to educate people what's going on. So I think talking to people at a level of a 5th grader or an 8th grader at the max, really making sure what you have really can reach everyone. And so you can't assume that they all know all these terms that we're talking about. I think that's incredibly important. And then we're trying to do this in a variety of ways. We're going to have some billboards. We're going to have some digital media. We're going to have some printed materials. We're going to have hopefully a bus wrapped like a colon. We have all these great ideas, but I think you have to diversify it. You can't just assume that someone's going to get it in one way or another. And so that would be my recommendation of really try to think about how to get it to everybody every adult who needs to understand what this is.
Yeah, most definitely. Miranda, do you use an outside vendor to assist with your Cologuard screening outreach and follow-up?
So yes, we have both internal team members who do outreach, and then through our relationship with the external vendor, which is Exact Sciences, they do outreach as well. So they have standardized outreach at intervals after the kit is sent to the patients, and even before, just to confirm address and insurance and things like that. And then beyond that, extended beyond that, if the patients still haven't returned their kits, our team will reach out to them. Our team also sends them a text message in advance, just so that they know that this really is coming from their trusted healthcare provider, which is their PCP or Erie Family Health Centers in general. And then we'll do telephone outreach after the fact if we haven't gotten a result.
Wow, excellent. And I think this kind of piggybacks on that, and it's for both of you. Patient navigation is a common theme with both presenters. Do you have any perils or struggles related to implementation and awareness of patient navigation services?
Well, I'll say for us, it's been an integral part of our program from the very beginning. And so we've really worked to make sure that our clinics work with Horizons to make sure they get the information they need. We navigate them to screening, and then we also navigate them if there's a positive screening test to go to colonoscopy. And so it's really, I'll tell you, in our Southwest region that already knew Horizons well, that has been a very seamless process. In our Eastern region, where Horizons really served more of the Southwest, just getting patients to know who Horizons is, what they do, has been a little bit more of a challenge. We're still working on that. So name recognition means a lot, and you can work on that and you can get that where it needs to be. But I think that's something that's incredibly important. So people know when that phone rings and it says Horizons, they understand what it is.
Yeah, I would say for us, from a provider perspective, we are just so grateful that there's someone else who can handle the outreach after we've identified that somebody needs to be screened for colon cancer. And so there's really no resistance internally from a provider standpoint to get those patients screened. I would say there are some patients who feel hesitant to answer a phone call from a number that they don't recognize, particularly our immigrant patient population. But what we've done on site is really been loud about at our different clinic locations about the importance of colon cancer screening, and that to expect that they may have outreach from an external party or from our own team to help them get screened for colon cancer. We also have a landing page on our webpage so that if patients have questions about the kit that they've received or the message they've received, they can very easily find that information that they're looking for right on the Erie website.
Wonderful. Well, we are at time. Thank you both so much. We have a couple extra questions. We might follow up with you later to get some responses on those. But again, congratulations on being part of our 2025 National Achievement Awardees. And thank you so much for being with us today. So before we move on to our closing panel, I would like to take a moment to hear from another colorectal cancer survivor, Natanya.
I had no reason to go, and going saved my life. If you have no symptoms and you don't feel the need to go for a colonoscopy, look at somebody like me.
Similar with Todd, I want to thank Natanya for sharing her story and letting us use it today. Just a little background. So Natanya's from New Jersey and was diagnosed with stage 2 colon cancer at 45 or at 48. And it was because her husband, who's an oncologist, urged her to get screening shortly after the age recommendation dropped from 50 to 45. So I think it really reiterates the importance of advocating for your loved ones, but also getting on-time screening. 1, 2, 3, 4, 5 years can really make all the difference. So again, I think it's a really important story to share and something to help us really guide our work. So I'd now like to welcome back our chairs, Steve and Gloria. Welcome, welcome. So Steve, I'd like to start with you. So reflecting on today's discussions, we heard about the latest CRC screening data, best practices, and successes around the country. What opportunities do you see for the roundtable, our members, and our partners who want to make an even bigger impact, not only on increasing screening rates, but reducing mortality from colorectal cancer?
Yes, and I have to just congratulate all of our awardees. I mean, the work that they're doing is really reaching some of the hardest to reach individuals. This is not easy work, but you can see how effective it can be when you have a team effort. I think the takeaways that I'm getting is on-time screening, and also really timely action when people have symptoms. So it was very encouraging to see the data where we're screening more people 45 to 49, and even in the entire age-eligible population, screening rates are going up. But still, 2/3 of people 45 to 49 are not getting screened. Only maybe 30% of them are. So we really need to double down there. And a very stubborn statistic is in the 50 to 54 group. We've been screening people over 50 for decades, and yet the 50 to 54-year-old group still hovers at around 50% screening rate. So there's a procrastination effect. There's all sorts of other competing issues. So I really would encourage people to take a look and take advantage of our lead time messaging guidebook, as Caitlin showed you. It really helps people try to get individuals younger than 45, even people in their 30s, 40s, to get screened at a timely fashion. So the resources that the Roundtable offers are extremely helpful. Most of them are very current and up to date, and a lot of work and research went into developing those guidebooks. Finally, we've heard a lot about symptoms, and people younger than 40 or 45 are getting cancer, and most of the time they present with symptoms, and the symptoms often are either not interpreted properly by their providers, or they're ignored, or the patient blows them off. We have to really start paying a lot more attention to symptoms, no matter what your age is, but especially in the young people who are not yet eligible to be screened yet. So more and more effort needs to be paid to really getting people who have symptoms in for colonoscopy.
Yeah, and I absolutely agree. And another aspect that we really made a point to highlight in the lead time messaging guidebook was having those tough discussions with your family, learning your family history, and then having the courage to talk to your doctor about that, because sometimes that can be challenging, and we recognize that. Gloria, I'd like to ask you the same question. What opportunities do you see, not only for our roundtable, but our members and our partners out in the field?
Yeah, I also want to congratulate the award winners and also say that the tele-echo program that Georgia has been running, I think is very successful. I think I and others have presented for that program in the past, and they really bring in a lot of a big audience. So kudos to them for that work. I also want to say that I was struck by the 34% screening rate in the 45 to 49 age group, and really actually saw that as a signal of hope, because we're already in 2025. And so it's very plausible that that number is probably climbed by another 15, 20% by now. And so I think that there's a lot of hope in the fact that the percentage that has been screened has actually risen quite rapidly when the U.S. Preventive Services Task Force guideline changed in 2021. So I see that as certainly an opportunity, but also a source of tremendous hope. And then I just wanted to reiterate what our partners shared, which was the value of partnerships. And I think that as we think about engaging kind of more community organizations, more people, talking to our family members about the importance of screening, we can't underscore the importance of that. And then I really liked what was said about kind of meeting patients where they are and going that extra step of sending out a text message or a phone call to say, hey, we've ordered a test for you, or doing the proactive outreach to say, hey, do you have somebody that can take you to your colonoscopy appointment? Because you will need a companion to go with you to that appointment. And so really making sure that patients are aware of the steps that are needed so that you have the greatest chance of getting them through that process. So really encouraged by what I heard today.
I think you're so right. And I think that's such a good point of, like you said, explaining and being sure to share the process, but also meet them where they're at with any, anxiety, fears, and helping them work through that. So I think that's incredibly important. So thank you. So one last question for you, Steve, before we jump. I think we might have some time for Q&A. But what else would you like to share about how the Roundtable is planning to work with our members and our partners across our priority areas?
I think that one of the priority areas that the Roundtable has not yet really had time to address is the timely initiation of treatment once cancer is diagnosed. And that's something we're getting more and more interested in because, for example, there are data from even 2023 where Blacks and whites, men and women, are being screened almost equally. And yet we know that Black men are 40% more likely to die of colon cancer, and Black women 30 or 35% more likely to die. So there's obviously issues related to disparities in mortality that goes beyond just the screening part of the equation. So we really need to focus a lot, I think, on once a cancer is diagnosed, the handoff from the gastroenterologist to the treatment team. And that can be complex. You know, we know that in each environment, it may get managed in different ways, but if we shine a light on that and we direct attention to that, I think we can make even more of an impact on mortality.
Yeah, absolutely. And, you know, before we move on, any last words of inspiration y'all want to share as we move through March?
Keep up the good work.
Yeah, keep up the great work.
work.
Get screened if you're due, and talk to your family about getting screened. I'm so excited about the partnership with American Greetings, and really appreciated, like, for each of these survivor videos, I just felt a chill down my spine in terms of just the impact of screening in saving lives from colon cancer.
Well, we are so appreciative of both of you, all you do in helping to lead us in our roundtable. So thank you both for joining and sharing all of your insight with us today. I just want to say that today has been really inspiring for me, and I'm very energized by this program as we continue to move through National Colorectal Cancer Awareness Month. I want to thank everybody who made today possible. I want to thank our wonderful speakers, our incredible awardees who are really making the impact, our entire NCCRT team who's helping to produce this event, and to all of our members and partners doing the work to reach those to save more lives from colorectal cancer. And for all of you joining us today, you are doing the important work in the field, and we are here to support you in any way that we can. So it is, you know, blatantly clear from the recent data that we have so much work to do to achieve our goals, but we are zeroing in our focus and making sure that we can do as much as we can. So I have one last request for everyone before you leave us. Please follow the link in the chat to take our brief survey. It helps us make these programs better for you. We'll also follow up via email. Again, this program is being recorded, so you'll receive that in the next few days. And then, of course, continue to engage with us on social media. We want to hear what everybody is doing across the country. Please sign up for our newsletter if you haven't already, and then you can learn more about membership if you're not a member. Last, I don't need to miss upcoming opportunities from the NCCRT this spring. We are working with some of our friends in ACS to host a webinar focused on screening in community health centers. We're really excited about. Dr. Keith Winfrey, one of our steering committee members, will be a presenter. We've also collected a list of member events from across the country, and you'll see that link as well. And then look out, in the next couple months, our rural colorectal cancer screening toolkit will be released. So we are very excited for that. And then last but not least, one of our favorite things is seeing all of the exciting energy around the country. If you know me, you know I love a giant inflatable colon, when bridges and buildings turn blue, and all of the awareness events. So we've been excited to receive these pictures from our members and our partners. And we'll close out with this last bit of inspiration for you. So with that, again, thank you all. Have a wonderful rest of your day and have a wonderful March.